go.
Betsy does the countdown to get everybody rock and
I
rolling.
love
Ahead,
that.
Neil.
All right, well, welcome back. This is episode 3 of 2024. Thank you for joining the nation. Tonight we have a great topic. We're joined by the Informed Consent team. We'll introduce you shortly here. And before we get into it, tonight we're talking about protecting doctors. And I love what we're doing, Reed, because DocNation, we're never shying away from fighting for doctors, fighting to bring them value, and never shying away from tough conversations either, and topics that are very, very important to doctors. Tonight's going to be one of those, so I'm excited to learn a little bit, and I'm excited about, and thank you for our guests and everybody that's joined the nation tonight. Reed, you guys have been doing a great job. I feel like I've been going around to a lot of different shows representing the industry side. That's who I am. And there's a lot of great conversations on kind of innovations in medicine and things like that. But just like in education, it's never as good as the teachers that are delivering it. Medicine's never is only as good as the doctors that are delivering it. And you guys are doing a great job for our doctors. Can you give us some updates with DocNation, what we're doing right now?
Hey, thanks, Neil. I appreciate that. I want to just start with a story, a meeting that I had earlier this morning. We've been at this thing for 15 years, servicing doctors in many, many different ways. And we had an intro call today, and the gentleman, and I'll keep it vague because he's a good friend of ours and he's on the call. I'll keep it vague, but there was some assistance needed from anywhere from personal, very, very personal stuff to let's run the practice. Help us run this practice. And he asked, can you help with this? And then on this topic, who do you recommend? And I was like, who do you recommend? Us. We do that stuff. And so this has really been a professional dream come true. DocNation has been around for a couple of years now. It's been in the works for many years, but it's really a dream come true to have an agency that supports physicians from A to Z. So when a physician comes to us and they need help on the services side, remember DocNation is 2 parts. We exist to serve physicians in many, many different aspects. You can look on our website to see that list. And you can set up a meeting with our team, our robust team, to go through those. It exists to do 2 things: the services side and the not-for-profit union. We're starting a union for physicians. It's a matter of time now, and I'll kick it to Justin to discuss the petition that we just kicked off.
Yeah, if you can, make a note after we're done tonight and tune into the change.org website. We have a petition there called Stop the Medicare Cuts for Physicians. And it's time for all of our voices to be united. This is way overdue. If you look at what was published recently by the AMA with reimbursements getting dropped even more, when everybody else has seen an increase with inflation at the level or a little bit higher than the level of what inflation was, doctors are the only ones that are getting hammered with cuts in this grouping that they were highlighting. And so it's time for us to really get united and join this. And so all we're asking for you to do is to go on there, sign it, and then share it with one person. You've got one colleague, I'm sure, that is behind this, that supports this. I can't think of a single doctor who wouldn't support this, but it's time for us to have our voices heard collectively. And so, yeah, thanks, Betsy, for putting that up for us. Go there, sign it, and then share it with one person. That's all we need, because if one person shares with one person, it's just going to take off like wildfire. We need our voices to be heard. Enough's enough, and this is going to be a great tidal wave of momentum that we're going to have to get our union in full swing.
We didn't start DocNation to become a very super successful services-oriented company. That's always been a part of DocNation, but the ultimate goal is to start DocNation to create a union and to get fair change for physicians across the country. And so, in year 2, we're just grateful. We're grateful for the overwhelming response we've gotten. We've been working with doctors for 15 plus years. We understood it. We knew the need was there, but for it to take off the way it's taken off has really been an awesome thing to be a part of. So very thankful to our signature members, and we're in a really, really good spot. All right, Neil, I'll kick it back to you.
Absolutely. Thank you for those updates. And that's huge news with that change.org and that petition there. Stop the Medicare cuts. That's another huge conversation that we need to continue, and we need your participation. It's awesome to see doctors banding together. And it's cool to be, you see, I'm wearing the DocNation t-shirt. I'm proud to stand with the physicians here.
Hey, and on one of our webinars, like 2 or 3 months ago, I said, let us know if you want a t-shirt. If you want a t-shirt, drop us a note and we'll send out t-shirts to people. We got some sweet t-shirts made.
That's awesome. Okay, so again, not shying away from any of these important issues for our doctors and fighting for them. I love how doctors are coming together and we're able to be a platform to keep doctors informed on issues. You know, people are coming to us, people are coming to you, Justin and Reed, all the time and giving their issues. And there were some, I'm just kind of a segue into introducing our informed consent team that's joined us today. There were some things that I did not know were taking place and happening in the lives of our doctors. So I'm going to kind of sit back a little bit, Reed, and allow the informed consent team to kind of take over, introduce themselves, and tell us what the problem is. They do a much better job articulating that than I do. So thank you guys for joining.
Let me jump in real quick. Justin and I have seen some egregious fouls made against physicians, and it's been happening for a very, very long time. It's disgusting. And DocNation exists to fight. We're here to fight. We have a service-oriented company. We know that very, very well. But DocNation exists to fight, and we don't make any qualms about that. And so we're just happy to have this level of knowledge on the screen with us. And so please introduce yourselves.
All right, I'm Usman Latif. I'm an interventional pain physician based in Kansas. I'll just tell you a little bit about myself. I originally started in internal medicine, trained at Wake Forest, was on faculty at Yale for a long time, ran some drug trials for Pfizer, and one day kind of saw the light, decided to start over. I did my anesthesia residency at Johns Hopkins, did my fellowship at the Harvard MGH program, ended up getting an MBA along the way, and ended up getting a certificate in value-based healthcare delivery from HBS. Now I'm in a very busy health system with about 10 other guys at the University of Kansas, working kind of in an academic private practice type of hybrid. And I got to know all these folks because Dr. Kloster, one of the co-founders of this company, is actually local to me. And we also share a common training at the Harvard MGH program. And one day he kind of took me aside and said, hey, can I tell you about something really interesting I'm working on? And that's when I kind of saw this is really interesting. It's something that I think people don't think about enough. And they've really come up with a novel way to attack the problem. So what I think what I'll do is let me introduce a little bit about what the problem is, and then I'm going to hand it off to these guys and let them kind of introduce themselves as we go along.
Sounds good.
So give me 1 second here, real fast. Yeah. Okay, you guys can see my screen there?
Yes.
Yep. Okay. So, you know, the problem here is basically informed consent. Informed consent is the linchpin of the relationship that we have between physicians and patients. And we go through medical school, and I think everyone agrees that this is a critical thing. You know, we are having patients coming to us, entrusting their care to us, and then we are trying to figure out what the issue is and what we can do, what we can offer to help with that, to alleviate the pain or alleviate the disease process that's there. And part of that is to have a very good and robust discussion about you know, what all the alternatives are, what we can offer them, what the risks are, what the benefits are, and what to expect as part of all of this. I don't think anyone will disagree about that. I think the problem and the unfortunate problem is that in reality, what we see as part of this process is very heterogeneous in real life, right? Not every patient who's going to get an epidural has exactly the same discussion with their physician or covers all of the same ground. And some of those discussions are very robust and some of them are very slim. You know, I've heard physicians say that, hey, you know, sometimes it's the end of the day and I'm really tired and done, you know, patients all day, and we just don't have it in me to have a 10-minute discussion. And so maybe we just get really brief with that one. And so it's one of those things where everyone agrees that it's important, but unfortunately in practice, it's not standardized. And the reason this is important is because it has medical legal ramifications. And these are critical because often when something happens, and it may be something that is, an expected possible adverse event that can happen from a procedure, then there may be some type of claim, and the patient may say, hey, I was never told that this could happen. And it could be possible that, they were told this, but there's no way to know for sure because the types of documentation we use are just really not very robust and not designed to accurately capture these conversations. And it could also be possible that maybe, the physician did, fail to mention that thing. But because there's not that transparency, it results in issues. So how big of a problem is, malpractice and being sued? There's a good study that looked at this in a database looking at about 25 years of data, about 15 years of data. And what they found was that the incidence of you having a malpractice claim was about 7.5%. So every single year, about 1 in 13 physicians are going to have a suit against them. And interestingly, by the age of 65 years, for those who are in high-risk specialties like procedural specialties, interventional radiology, interventional pain, spine surgery, whatever it may be, it's 99% of physicians will have at least one claim against them. And this to me was really, really shocking, right? Because no one goes out to be a physician and says, hey, I'm probably going to get sued, right? You think that only happens to terrible physicians, or that's only if you, make these huge, huge, terrible mistakes. But it's really just kind of inevitable, and that doesn't, count whether or not it's a legitimate claim or not, but it's just going to happen. So if you break this out and look at the age groups, what you see is that as you get older and the further you get out from residency, it kind of almost plateaus and it becomes almost nearly inevitable that this will happen. And that really starts to peak kind of around maybe age 40, 45. So pretty quickly after you get established in your practice. The other thing is, if you look at low risk and high risk specialties, there are payments that are actually made, indemnity payments, right? So if either the suit is settled or you lose the suit or whatever it might be, there's some kind of payment. And look at in these high risk procedural specialties, those indemnity payments are almost 3 to 4 times what you would see in low risk. So this is all, to me, was pretty shocking data. Now, you look at all this and say, okay, this sounds terrible. So then the question is, what can we do about it, right? So if we want to know what we can do about it, we need to know what drives these suits. What's driving these claims? So there's another study, it's pretty large, looked at about 35 years of data from a medical legal database. And what they found was that in malpractice lawsuits, informed consent was a very significant allegation. And in fact, in 2 separate studies of malpractice cases that involved a high-risk specialty, in this case, cervical spinal surgery, more than 50% of the suits were actually using informed consent as the basis for the suit. And so what this tells us is that almost everyone is going to have a suit at some point, and the vast majority of these are going to be centered around informed consent. So I'm going to stop this here real fast. So I think this kind of provides a really good starting point for this discussion. It sounds like, there is an inherent harm here, and it's pretty significant, and it's going to affect all of us as physicians. The impact is huge, and we kind of have a good idea of where we could focus if we're trying to solve some of this, both for the benefit of protecting us medically legally, but also for the benefit of our patients in terms of improving transparency. So let me hand it off to Dr. Dan Kloster here, and I think he'll kind of talk to you through his interesting journey of this.
Yeah, well, thanks, Usman, first of all. And yeah, so I'm private practice, Kansas City. So Usman and I are good friends, trained at Mass General as well for my pain fellowship. I'm a very interventional guy. And Usman just hit a lot of points that exactly happened to me, right? I mean, I grew up, my dad's a retired surgeon. I grew up in a small town in North Dakota. I was around this field my entire life. And you don't think you're going to get sued. But I got sued on a known complication. Okay, so I got sued on an epidural hematoma. The patient, we recognized it immediately. He recovered, required surgery, no deficits. And just shy of 2 years later, I get served with a lawsuit. And I can't tell you how frustrating that is from a doc standpoint, because I did everything right. The patient fully recovered. We didn't ignore anything. And meanwhile, it was the lawsuit was I had never told him about this. Well, consents, unfortunately, have very, very little value in a court of law because most of us have grown up in this stage, and they probably still do. We use the same consent form for a heart transplant as an epidural, right? You please fill in the line, and we all do that. They fill in the line, but there's no really proof that you've had the conversation. So I said, there has got to be a better mousetrap. And that's where I came up with this idea that we have to videotape the patient watching an informed, consistent consent. And so it's procedure specific. So if you're getting an epidural, you're watching an epidural consent. If you are having a knee replacement, you're getting a knee replacement. And so that was really the genesis, is I just really felt frustrated that if I did everything right, I communicated with the patient, and nonetheless, I had a known complication, not something that, it was just a known complication. It happens. And meanwhile, I'm engaged in a lawsuit. So I'll just take a pause there, but that's kind of the genesis of the whole idea.
My name's Bruce Keplinger. I'm an attorney. I've defended physicians for 40 years. I've handled thousands of cases. I've tried about 100 medical malpractice cases to jury verdict. And when I heard about this, when Dr. Kloster first told me about his idea and his product and showed it to me, and I was very excited about it because, and as I said, I'm on the defense side. I've heard thousands of patients tell me at their depositions, he or she didn't tell me about the complication that happened. And we now, if people use informed consent, we, number one, have a very good and legally sufficient informed consent presentation. And we have proof that the patient watched it. And you'll see the technology of that from somebody else. I don't understand the technology at all, but we have a proof that the patient watched it. And the third thing I liked about it is the patient has access to the informed consent discussion as much as they want. They're not confined to just hearing it in the physician's office. In a physician's office, patients are very poor listeners and have very poor retention. And there's also studies on that Dr. Latif probably has to show us if we had time to look at them. But in the physician's office or in the holding room before surgery, they're scared, they're disoriented, they're intimidated, and 9 out of 10 of them were never trained to be good listeners anyway. So they're, I think often when they say the doctor didn't tell me that I could have a hematoma from this epidural, they would probably pass a lie detector test on that, even though, and lie detectors are inadmissible, so that's probably a bad example. But
we get what
even though Dr. Kloster absolutely did say hematoma, they were truthfully saying, I didn't hear that because they didn't hear it. And this informed consent product just solves, well, nothing can solve the problem, but it highly alleviates the problem because it's incontrovertible proof that the patient was told, and they have as many times to listen to it as possible. So I think this would greatly, if widely used, it would greatly reduce the number of suits that allege lack of informed consent. And at that point, I'll be quiet.
Thanks, Bruce. I'm Brad Hancock, and while I'm introducing myself, Betsy, if you could tee up the deck. I've been in medical industry for about 30 years. I was with Medtronic for 20 years in the cardiac rhythm management, neuromodulation, and spine division after they acquired Sophomore Danek. And then I went to St. Jude Medical before they were acquired by Abbott. I ran the international neuromodulation division. And I came over here about, I guess, 2.5 years ago. I'd known Dr. Kloster for probably 20 years, and we were out in Omaha. We were doing a cancer symposium, cancer pain. And he sat down and he said, first of all, sign this NDA, which always makes you a little nervous. But then he laid out, this vision for creating this platform that was intended to do a couple of things. Number one is protect physicians from a malpractice claim related to informed consent. But the other one, and it was just as meaningful to me, was he knew that patients would leave his office and that they wouldn't remember maybe 25% of what he told them. And they'd go home and the family member would say, well, what did Dr. Kloster tell you? He said, I have to have surgery, right? And so that really resonated with me. And so I made the jump about 2.5 years ago. We spent the first 1.5 years developing the app, and then the last year developing these procedure-specific videos. And we are absolutely thrilled to have the opportunity tonight to join all of you and talk a little bit about our platform. So we can go to the next one, and I'm going to go through these pretty quickly because Usman already laid out the issue. But as reimbursement is going down, unfortunately, malpractice payments and malpractice cases are going up. In 2022, about $4 billion was awarded in litigated malpractice cases.
Hey, Brad, I'm going to interrupt just real quick. We're not seeing the slides move, at least on mine vision. So we're still on the.
Betsy, can you?
Yeah, she's working on it. She's probably.
Did you say 4 billion?
$4 billion.
Let's talk about that for a second.
Yeah, $4 billion. 57 verdicts over $10 million and greater than 10,000 payment. There we go. And this number is going up. It's increasing. It's not going down. And the reason it's going up is that tort reform is being rolled back in a lot of states. So in a lot of states, you used to have caps on the awards. Those caps have been taken away in a lot of cases. And I'm going to ask my partner here, Bruce, to just comment on what's happening in the malpractice arena.
Well, several things caused the verdicts to be, there are a few more plaintiff's verdicts than there used to be, but the plaintiff's verdicts are usually much higher. Caps are being found unconstitutional in many states, and plaintiff's bar is becoming more and more sophisticated. And the caps were on pain and suffering type damages anyway. Plaintiffs are being more aggressive in dressing up most of their damages as economic damages, using life care plans, day in the life films, things like that. That's where you get these, and there's some verdicts over $100 million as you showed, but and juries are if doctors are getting more and more specialized and not the family doctor anymore, the doctors are strangers to the patients, and the patients have no problem in suing them. So many reasons, but Brad is correct. There are more verdicts against physicians, and they are for higher amounts. And as you're probably going to get to, that also leads to higher premiums.
Wait, can we go back real quick on
Next slide. Go ahead.
Unconstitutional? How did that become?
Well, well, it's hard for me. Most, well, because state Supreme Court justices, either directly or indirectly, are responsive to political pressure and who appointed them. And they find ways. In Kansas, it was found unconstitutional because it violated the right to trial by jury. Other places, they say it violates equal protection. Other places, they say it violates due process, or they find something in the state constitution that's not in the U.S. Constitution. But yeah, the caps are being found unconstitutional in many states.
Justin, are you hearing what I'm hearing here? This is politicians again, right?
Yep.
Well, I'm just thinking about, at the end of the day, the quality of healthcare and the doctor-patient relationship. And is this whole situation, this malpractice side, how is this making it better? Because we go after this petition with stopping the cuts to Medicare, where at the end of the day, patients are suffering from this. So I know our audience is doctors here, but like, how are we getting any better? How is these changes, these rulings, all these things, how is that actually making things better for the patients? And I'm not really saying that there's much of a correlation to that.
Well, in my view, and I don't do all the talking, but in my view, it actually makes it worse, because it makes physicians practice more defensive medicine,
Right?
do unnecessary procedures, unnecessary tests,
Yep.
just to protect unnecessary second opinions,
Yep.
which drive up costs. And the more procedures that are done, the more chances there are for a known complication to occur. So yeah, I do not think that active, of course, if there were a plaintiff's lawyer on this panel, he or she would say, oh, we're making the doctors be more careful. But
That's right.
it's actually 46 years of my experience. I don't see that the lawsuit, but it's the system we have. So this informed consent product at least cuts down a major area of suits if it were widely used.
It's the whole point of the union side of DocNation. And unfortunately, we have to get heavily political to get changes, to have changes made across the country. And it's something that DocNation is and will be fighting for in the coming year.
You know, it's not only the risk of financial payment, but this first data point here, this is one that probably blew me away more than anything else. But on average, a physician will spend more than 4 years defending a malpractice claim. And Dr. Kloster talked about the stress that he was going through when he was involved in this. And you can imagine that this probably goes up, you know, depending on the specialty. And at any given time, you have 1 out of 4 surgeons engaged in litigation. The average cost of defending a malpractice claim is almost $50,000. The average payout is over $350,000. And I'll ask Bruce to add a little color because those numbers are a little bit misleading.
Well, yeah, for the average cost to be as low as 47,000, that means the database includes cases that are filed and immediately dismissed, because cases that are defended for a while and then settled cost twice as much as that, and cases that are taken through trial costs 5 times as much as that or more.
Mhm.
And payouts include nuisance value payouts. If you were just talking about verdicts, it would be, I think, in the range of 800 to 900,000. So those numbers, while they look big, are actually low.
Small. Bruce, I don't mean to pick on you here, but I'm just thinking about the industry and your profession. Tell us about your perspective on this whole problem that exists. Like, how are the lawyers contributing to this, or the insurance companies, or all the players involved? Like, what are you seeing? You said 40 some years. Tell us about that.
Well, the plaintiff's bar is very politically sophisticated. 10 or 15 years ago, the trial lawyer plaintiff's bar passed unions as the largest contributors to political campaigns. And now federal employee unions are the biggest of the unions, but that's a different thing. So they, and judges are either elected directly or they're appointed by people who are elected.
Mhm.
And just to be crass about it, follow the money.
That's right. Bingo.
And then, can you give us an estimate on what the dues are per attorney that are part of these unions? Like, what are you seeing on the plaintiff side?
Oh, gosh,
Any idea?
I have, I really don't. I would say several $1,000s.
That's why I
a year,
love these
but
webinars, because this is not planned. Justin's putting Bruce on the
it's
spot.
several $1,000s a year.
I'm just thinking about the battle that we're up against, and I
Yep.
want people to have a honest understanding of
Yep.
what this is going to take. We all have to come together, lock arms to make this possible, and we can do it. We have the numbers on our side. Like, that's
Yeah.
not the question. It's just a
Well,
matter of us getting united.
Yeah, I would say in the $2,000 to $5,000 range if a year per
Yeah.
lawyer, if you made me guess.
Yeah.
But then the lawyers directly contribute to many campaigns without going through a group. That's probably just, they're spending a lot more money than their dues, but their dues are substantial.
Sure.
You know, it's not only the plaintiffs' lawyers that are driving up these awards, but there's one data point here like I absolutely couldn't believe, but I read an article about hedge funds are actively investing in malpractice cases. So they'll go out and perhaps you have a patient that hasn't, you know, has been harmed, or they think they have a case, but they don't have the funds to actually take it to trial. The hedge funds will come in, and if they think that there's a good chance that that patient can win that case, they will invest in that, just like they invest in a company. And that's clearly not helping at all.
Next
slide.
I thought everybody knew that, or I would have mentioned it. No, there's scores of hedge funds that all they do is finance litigation.
Not mine.
I'll be honest, I did not know that.
That's scary.
Conflict of interest?
A little bit.
No, they're investors. It's like you go to the bank and lend and borrow. The plaintiff could go to the bank and say, lend me $100,000 because I want to sue my doctor, but the bank wouldn't do it. But hedge funds will. Some hedge funds will.
Hmm.
And they're usually named after minor Greek gods for some reason, but
Twisted.
And you know what? And one of the issues that Dan wanted to make sure that we talked about is most physicians carry a maximum of $1 million in coverage. But as we've heard, and you can see on this slide, you know, 110 million in Minnesota, 135 in Detroit. $1 million isn't going to cover that. And I think as these awards are increasing, and I think Bruce just mentioned, if it litigates, goes to trial, it's close to $1 million. On top of that, you have the lawyer's fees. You may find physicians are in a position where that $1 million doesn't cover the award and all the cost of defending that case. And then this last bullet here, and Bruce is going to talk about this a little bit as well, but if you're a physician and you have made a payment, you're then 4 times more likely to make another malpractice payment within 5 years.
Okay, hold on. What does that mean?
So that
well,
means, go ahead, Bruce.
go ahead. Well, everything's a bell curve, and there are some physicians who get sued more because they are not at the time. You know, perhaps they're doing procedures they weren't properly trained for, or perhaps they've lost their skills, but they keep doing it. So there are valid malpractice cases out there, and physicians who deserve to be sued do get sued more often. So that's part of it. But the main part of it, in my opinion, is that once a physician is known in the plaintiff's bar community to have had a payment made on her or his behalf, it's more likely that if another potential claim comes up, that the plaintiff's bar would be willing to take it on, because once again, to be crass, there's blood in the water.
Yeah.
Right.
Can you speak to any examples of what, for a physician who has $110 million or 135, or just some number that's way beyond the limits of the policy, what happens to them?
Well, first of all, they asked the judge to reduce the verdict to see that it's because it doesn't conform to the evidence. And then they asked the appellate court to reduce it. If they don't have personal counsel before this, unfortunately, they hire personal counsel, and the personal counsel goes against the insurance company to say you didn't adequately protect me. And while all of that's going on, they're negotiating to try to settle it. And fortunately, all the cases I tried, I never had a excess verdict that a physician had to pay money on that I can recall. But they do happen. But and then at the end of the negative rainbow, the physician takes bankruptcy.
Jeez. Back to Usman's point about,
Yeah.
do you know a doctor who got into this profession thinking they were going to get sued? Right. And we're this deep into this conversation.
Yeah. Next slide, Betsy. There's really 2 factors that are going to impact whether you're going to be sued. One is the specialty, and if you're a general surgeon, you're going to get sued. OBGYN, ortho, plastic, and pain management is starting to increase because of the wider adoption of procedures they're doing. That's one. The other one is where you live. If you're in the Northeast, there's a greater chance that you're going to be involved in a malpractice case. In the flyover country, I'm in Minnesota, Dan's in Kansas. You know, our malpractice premiums are pretty low. The payments aren't out of the world. But if you're on the left coast or the right coast and you're doing surgery, the penalties can be pretty severe. And then the last slide, obviously, as these awards are going up, premiums are going up. And this year, I think I talked to a couple malpractice brokers, and they said this year between 15 and 20% increases in malpractice premiums. In New York, I think OBGYN right now is about $150,000 for your malpractice coverage. And then some of these states, Illinois was almost a 60% increase, West Virginia 41, and down the line. So clearly there's a direct correlation between the payments going up, the number of cases increasing, and the fact that the malpractice premiums are rising as well.
So Dan and Usman, where along the way did you, on the previous slide where it showed the bars and the per specialty and the percentage chance of
Yep.
getting sued. Where along your training pipeline did you become aware of this?
Yeah, well, I'll just say you don't, right? I mean, you go in, listen, doctors wear the label proudly. I mean, we take care of patients, we identify as healers or treaters, and we go into it for that reason. And you're not going in, to Usman's point, that you're going to get sued. But unfortunately, we're in an industry that, consequences happen, things happen. And it just kind of comes back to the known complications. I mean, nerve injury happens, things will happen. And you just, the patient is, not happy. Something happened to them. They just felt that they'd been harmed. And even though you've told them and informed, and I think it's a really point that Usman made as well, that depending on the end of the day, and, some people tell the story better than other people. I mean, I know what I tell my patients. I think I'm very good at it, but I've been doing this for 25 years. And so when I discuss a spinal cord stimulator, if I discuss an epidural, I think I'm very articulate. I think I'm well versed. I explain it all. And then I walk out and pat myself on the back. Well, that patient's heard it once. I've given that speech thousands of times. So it's like being an actor. I mean, I know what I've said, but they've heard it one time. And I go out and I said, oh, no, they understand everything I said. They nodded the right time. They asked the appropriate question. They smiled when we were done. They said, yep, I want to do this. And they walk to the waiting room and go out to the car with their wife or spouse or husband. And they're like, what did Dr. Kloster say? I'm getting surgery. I mean, that's the extent of what they've taken home, even though I really had this detailed conversation. And I think Usman can go into the next point, that now how do we solve this problem? What do we have to solve?
I've got my eye on the clock, and I think we should show them the solution.
Yeah. Let's do that.
Let's get into it.
All right. Let me pull some things up here. Yeah, I think that's an interesting point. There's so much stuff in medical school. Like, we learn how to become a good doctor, but what we don't learn is the business of medicine, things around, legal ramifications, all of this stuff you find out later. And it would be really great if we were kind of having a more structured presentation as we were going along. So, Dan's kind of hitting on the head with what the issue is here, right? That we need to have a better vehicle or platform to present the informed consent to the patient. We want to do all of this for the patient's benefit, right? We want the patient to fully understand what is going to happen. What does the procedure entail? What does the surgery entail? We want them to fully understand what are the potential benefits and what are the potential risks, and what can you expect before the procedure and after the procedure, right? And I think if everyone has that shared understanding, then it's going to be much better. So naturally, video seems to be a good way to do this, right? Because then we can really fine tune that delivery and the content and make sure that every single time you do it, it's the same, right? It doesn't vary. So does it work? Does it work for consent? There's actually a pretty big study from a company called Engaged MD that has a multimedia platform that just displays different videos, and they're mostly in the OB space. And so there was a very large study with over 6,000 patients in more than a dozen centers in the US and over 100 providers. And they basically randomized the groups into people who got to have a multimedia consent versus ones who did not. And what they found was that 86% of patients felt that the multimedia platform better prepared them to sign the consent. And 77% of them felt that they were much more comfortable about pursuing the treatment that they were going to undergo. And this, I thought, was, and that's an interesting point too, because there's a lot of times when patients come in and we know exactly what we need to do for this patient to help them with their issue. And then they just don't show up for the procedure. And often we don't know what happened along the way, but a lot of times those patients will then resurface like 3-4 years later and say, hey, doc, here's my problem. And I look back at my note and I'm like, that's the exact same problem you had 4 years ago. And I told you that this is the thing that we need to do to fix that. And he's like, yeah, but then I saw this thing on the internet and it said you can go blind and die. And I'm like, that's not even a realistic, that has nothing to do with, I don't even know what you were looking at. right? And so I think it's not just that we want them to know what are the legitimate things that can go wrong with things, but we also want to know these are the only things. These other things that you see, that those aren't possible, right? And so I think if we can get more people to actually pursue treatment that's to their benefit, that's a good thing. But the other thing was that 83% of patients actually said that it improved their satisfaction with their care. And I thought this was really interesting because nothing changed about the care. But literally just understanding the care better made them more satisfied with the care that you were delivering anyway. And obviously, we want all our patients to be satisfied, have good patient satisfaction, but also with the way that things are going right now with payers, there's all these new metrics coming out that are tying parts of payments to patient satisfaction type of metrics. And so I think this is, I think, a really interesting point. So what is the solution here? Informed consent. And I'm just going to kind of preface for a second. I'm not one of the founders of this company. Dan Kloster was one of the co-founders. Brad Hancock is one of the CEOs. The rest of us, we're on the advisory board, or we've helped in different ways. And I have a big tech background, and I've been helping a little bit with the tech stack and with some of the other things around this. But otherwise, I'm a paid consultant, and I've done some research on this product in our field. But the product essentially is this: the patient comes in, you hand them this iPad. The iPad is loaded with this platform. On there, you can pick the patient from the list, and then you have a list of different procedures. And it's incredibly expansive. And later, Brad and Dan can talk to all the different specialties on board and how much it's growing. But pretty much anything in your field, it's going to be in there. And you're going to just pick that, and the patient is now going to view that video. Now, as they view that video, they're going to see, what is this procedure? They're going to see animations of it to show, like, how does it work? They're going to understand, like, what to expect before the procedure, what to expect after the procedure, what are the risks and benefits. And most importantly, we want to make sure the patient is actually watching it and having a chance to comprehend this. And so there's artificial intelligence technology that tracks their face and their eyeballs. And you can see when they look away, it pauses.
Yeah.
And it will not continue until they look at it again.
That's cool.
Yeah.
It is.
Yes.
And this is critical, right? Because we don't want to be like, well, the thing was playing, but I didn't really watch
Yes.
it, or I walked away. Because not just because from a malpractice perspective, but because this is important information. We want the patient to have this information. And so every time they look away, it will pause. And until they have watched the entire thing to the end, they cannot sign their consent. Okay. So that, I think, is really critical. Also, all of this, right? The video that they're watching and the video of themselves watching it and the eyeball tracking data, all of this becomes part of the permanent durable record. So, if 6 years ago this thing comes up and says, you never told me that this could happen, or you never told me about the procedure, we not only have the video outlining all the things, but we have a video of you watching it, right? Also, from kind of a patient perspective, now everyone learns in different ways. Now you're presenting the data in visual form, in audio form, and at the end, in written form. And so you kind of have this trifecta where you are maximizing the likelihood that not only are you doing a good job with informed consent, but that you're serving that patient well by allowing them to comprehend it.
Dr. Latif,
ahead.
I love that. That is
So do I.
amazing. Talking about consuming information, and there's a lot of social media. People like the videos, and they'll understand a little bit better. Talking about patient satisfaction and being agreeable and understanding what procedures they're in. Sounds to me like a lot of these device companies should be standing with physicians and investing in this as well. Brad, you said you worked for Medtronic and St. Jude and ANS. Sounds like
Neil, you're spot on. We're talking to several companies right now, and I'm going to actually turn it over to Dan because he's a little bit better talking about this. But we know within our world of pain management that adoption of a lot of the procedures that are offered is very low. Dan, you want to pick it up?
Yeah, and so what Brad's talking about, so first of all, I built this for everything we've discussed up to this point, right? So to protect doctors, to empower doctors, but also to educate patients. And the happy accident on all this was once the patient's educated, they're more likely to feel comfortable proceeding with the proposed surgery or procedure. And, I'm a pain physician, so I'm going to speak to pain terms, but spinal cord stimulator is a very common thing that I do. Dr. Usman does numerous of these as well. But the adoption rate is a little less than 20% industry-wide, and that's talking Medtronic, Abbott, any of this. But in my clinic, we took a 6-month sample, and out of 70 some patients, we've already implanted like 50, some of them over 6 months. It was a 70% adoption, and the industry average is 20%. So when the industry heard this, to Neil's point, they have been very excited because, you know, everyone wants to drive their revenue, but also patients need these treatments. And once they're educated, they feel comfortable. So I'll give you another example of everyone has a bad knee. You'd think everyone would get the knee replaced, right? And you need a knee replacement, 100% of people get on the table. If you look at those stats, only about 35% of people that need a knee replacement get a knee replacement. And that is just stunning to me. And it's kind of to Dr. Latif, what he said earlier is they might read something that scares the heck out of them. It's like, oh my God, I'm going to die. I'm going to do this and that. And they just are miserable for 3 or 4 years while their health declines, right? So if that patient gets a knee replacement, well, they can rehab it, they can be more active, they can walk, it's better for the heart, the lungs, and everything. So it's not just driving revenue, that's a happy accident, but it's empowering the patient to get better treatment and have a treatment that's necessary. And also, again, protecting the physician. So I protected the physician with this, but the happy accident was patients are more adoptive of therapies.
And this is way better than the brochure and a Google search.
Yeah. Yeah. Thank you.
So,
yes.
And then Dan, you said it jumped from like 20-something% to 70. So almost three times more adoption.
Yes, yeah. And so, and because the patient gets the video at home. So I don't know if we covered that at all, but when the patient signs on the iPad, they get an emailed copy immediately to their, whatever their account is, their email account. It'll hit that immediately. And on average, they share it about 3 times. So everyone has a doctor or nurse in their family. Someone's living in California or Florida, and they can send this, they can forward it on, and they can have that conversation. And back to the patient satisfaction, to, you know, Dr. Latif said, you know, we're not doing anything different. We have the same discussion, but the patient is more satisfied. And I've had patients come back and just say, you know what, I just love this, that my husband and I watched this, or I sent it to my daughter and she watched it, and now we all understand why we're talking about this, and we want to proceed. So it really, it's just a very good educational tool for the family.
Yeah, and I think to that point, you know, all of us in any kind of procedural field have experienced this, where the patient comes in and says, oh man, I really wish my husband was here. He's the one who really gets this question. Or my daughter's gonna ask me so many questions that I'm not gonna tell them. Or can you write this all down, right? And I might be able to write down a few things, but I can't write down all of that stuff. And then, you know, we get so many calls then later, you know, oh, you know, I'm the daughter of so-and-so, or I'm the spouse of so-and-so, and they came in and can you call me and just tell me? And so we've already invested a lot of time that was very worthwhile with this patient, and then you have to just repeat it. And so this allows you to kind of scale your efforts, right? So it should, and I'm just going to quickly just launch into this. This kind of segues into, we did a little study on this to look at, you know, what does this look like in kind of a multi-center implementation. And so I led this study along with Dr. Tim Deere and Dr. Sean Lee. And I think we had like maybe 6 different centers throughout the US that implemented this and then looked at outcomes. And what they found was that physicians felt that there was improved patient satisfaction. Providers were very satisfied with it. They felt across the board that there was time savings, and that it was adding value to their practice, and was more thoroughness. So physicians were self-judging that, hey, when I use this, I actually think the consent is more thorough. So like, you know, we're usually hesitant to say, hey, we're not perfect, right? And so I think that's pretty high for people to kind of recognize that. And they actually saw in the study, we were seeing from kind of doing a thematic analysis of the feedback that we were getting from the different sites, is that they actually felt there was improved efficiency of their clinic, and they were reducing calls, which is huge, right? So we've talked about reducing calls and trying to make it better for patients to be able to watch this video on demand, but there's actually improvements in clinic efficiency as well. So there's an interesting study from the cardiology literature that's actually from, you know, more than a decade ago, and they just implemented something where they would just show a video. And so it didn't even have this kind of like legal premise around it. It was just a video that would help explain the procedure again and the risks and benefits. And then someone would come in and just do an old fashioned, you know, paper consent. And they found that they were saving about 10 minutes per case in a busy setting. And
Wow.
so if you model this out, that would be an extra hour a day of open angio suite time, which means either you could have more throughput and generate more revenue and get more patients served and, let people have their appointment sooner, which of course, everyone loves, or you could just close down an hour earlier and everyone gets back an hour of their day. You cut down on staff and cost of delivering the same amount of care. And so if you kind of apply this out to whatever field it is that you're in, you're either going to see a reduced cost in running your practice or potentially improved throughput and productivity. So I think that's pretty huge.
That is. Wow.
I'll just
Let
tag
me throw
along
in
with
one thing that the doctors haven't mentioned that they know as part of this. There could be people watching this or listening to this that think, well, yeah, but there still has to be some interaction between the actual physician, the actual patient, because every patient is different, but it does allow for that. If the patient says, well, this covers the generic patient, but I have this specific syndrome, and how does that apply? That's where the decades of training by the actual physician kicks in. And they say, well, we're adjusting your procedure this way to react to your specific situation. And so we're not replacing the doctor with the person who did the video. We're helping the doctor with the person in the video, but the doctor can still fine tune in any way she or he wishes based on the individual patient. So it's not all animated, but it's much more efficient. It's much more consistent and much more cost effective. And one other thing I want to mention while I have the floor is we talked about claims. Most insurance companies, if a plaintiff's lawyer, well, there's claims and lawsuits. If a plaintiff's lawyer writes a letter to a doctor and says, my patient says they weren't warned about a hematoma from this spinal epidural, and if the doctor's office or the insurance company can reply to the plaintiff saying, well, here's a thumb drive with a video of your patient, your client watching while they were told about the hematoma, then there's never a suit filed. And you're absolutely helping the statistics. So it stops things. There are many more satisfied patients who would never go see a lawyer because they would remember that they saw it. But if they do go see a lawyer, there's incontrovertible proof that they were warned. So
what's the video library like in terms of where you want to be with the scope of these procedures? You have the educational material for them to watch and to essentially understand the fullness of what could happen and educating them. Are you guys done producing that library for the most part, or is there still a ways to go? How comprehensive is it?
Yeah, Justin, great question. We've got, I would say, about a third of the way there. So we've got orthopedic, we've got spine, interventional radiology, anesthesia, bariatric plastic surgery, obviously pain management, regenerative. We're working on general surgery and urology, but the plan is to have a full library to support all of the specialties.
And one of the things I was mention, one of the things I was just going to mention is, the workflows for doing this is pretty huge, right? I mean, you have to come with a script, you have to come up with all these things, you might have to have an actor, you have to make animations and things like that. And I think this company has done a really great job of trying to integrate as much AI into every piece of this kind of puzzle to improve that. And so they have a really efficient workflow now to be able to generate these in a much, much shortened timeline. And so what that means is that it's going to grow very, very.
Oh, we lost the tech guy. The tech guy.
It was going to grow very rapidly. I think I'll finish it for him.
No, there he is again.
You're back. Keep going, Usman.
Oh, sorry. Did it cut out?
Yeah.
He says it's grow very, very fast or something like that.
Yeah, sorry. So I was just saying, I think with this new tech stack that they have using AI to generate all this stuff, if you're out there and you want to see your specialty represented in this, just reach out because I know that they can scale it up very quickly.
Awesome.
Yeah, great point.
Very encouraging. I'm still blown away a little bit.
So am I. So the DocNation team here, we didn't get to see the full thing until now. And I can't help but, we're serving physicians, but I can't help but think about my own situation. And we have a 5-year-old and we're getting ready to have our 4th baby, 5 years old and under, and epidural happens every time. I feel so uneducated on epidurals and what it means and what are we doing. I just know it takes the pain away. And I feel like a decently educated guy, but wow, how far off I am. I don't at all feel that it takes away from the physician-patient relationship. I think what it does is it drives home our ability to communicate amongst each other and our family members and retain information because, like Usman said, we all learn differently. And if I can watch a video, I won't forget it. But if I have to read it with kids in the background, my wife saying something, or if I have to read it and that's it, I'm going to forget a good portion of it. I once heard that you have to hear things 7 times to be able to retain the information if you hear it audibly. And so the way we connect here, you guys connect here on all 3 ways of communication is huge. Hey, for the audience here, if you want to get connected with this group, DocNation would be happy to broker that relationship and reach out to us. And I think everybody at this point knows how to reach out to us. Last words, Neil. I'm kind of taking over your role here, but I see you stiff arming the dog. So I'm like,
the dog wanted to be on camera.
Neil's a stud basketball player, and I feel like the dog's been over there trying to set a screen on him this whole video.
Gosh. I'll give the closing words to you.
Well, hold on, we have a question.
Okay,
Sorry,
let's do that.
There's a question from our attendees. So if you have a question, please submit it now before we wrap up. But the question here is, who is writing the AI program? So can you speak to?
So I can take that one.
Yeah, great question.
Yeah. So one of the things when I got brought in, so just outside of what I do here on the side, even outside of my medical practice, I run multiple companies that develop AI solutions outside of medicine for all kinds of things like how do you prevent catfishing and online dating, just kind of totally random things. And so one of the things when they kind of brought me in was to look at their whole tech team and kind of see how everything's working. So they have a dedicated team that's doing all the development. They're using a variety of different architectures and technologies as building blocks for this. The stuff that's being used for computer vision is out of existing libraries, and they're just being implemented in novel ways to do the face tracking and the eyeball tracking. For the things that are being done in terms of like the content creation and all of that, that is a hybrid process where they have technologies that have already been developed out there. They're being used to help develop, like say, the video and things like that. But everything is being moderated by humans, because what we don't want is, videos out there that are inaccurate or things like that. So I think that's an important point to make. And I think especially with everything we see in AI right now, we're using the AI to do the cool stuff, but everything is under like the steady and watchful hand of physician experts. And I think Informed Consent has done a good job about, for every single field that they're launching, they bring in subject matter experts to make sure that everything is consistent with what they see in practice.
Yeah, so it's written by each script is written by an attorney, so, and then vetted by a specialist in that field. So if it's total knee replacement, the risk of that is the same whether you're on Kansas City, Florida, or California, but we have an attorney write that script. Then it's vetted by an orthopedic surgeon who specializes in knee replacements, and then we turn it into the video. And so, yeah, so each one is very specific.
Have you had a case where this evidence was produced and there was a situation and the outcome was fill in the blank? Like, tell us about.
Yeah, no, so that's kind of the holy grail. And we've officially launched about 6 months ago. So we don't have that. Yep. And statistically, we want that, right? We want that case to happen. We don't ever want it to happen, but we want it to happen. So at this point, it hasn't happened, but we feel prepared. If it's a known complication and it's a known complication, we feel that we have it covered.
DocNation is a company that has a ton of experience, but we're only 2 years old, right? So we totally understand where you're at, and the timing is really good. I'm sure Dan wants to say, hey, Justin, I wish I would have had it, 15 years ago when I had my problem.
Yeah, but it's like dentists preventing all cavities, and then the dentist won't have anything to do that. But it may be a while before this case comes up, because all of these patients are actually informed. Yeah. And they say, well, he told me it was going to happen, and it happened. So it actually it'll be hard to prove that the product works because it's working so well.
Well, it'll be fun to watch the numbers go down. All those
Right. That's right.
climbing numbers getting worse and worse.
Yeah.
You guys are gonna make a dent now. I'm excited to see the outcome.
Well, gentlemen,
Yeah.
DocNation is excited to lock arms with you guys in our pursuit to protect physicians. One of our core focuses is to help doctors make, manage, and protect themselves, their money, their future, their focus, and their profession. But this thing did one step further for me, and that was the reason you guys got into this was to serve people, right? To serve people. And at the end of the day, I'm almost thinking that's bigger and more important than the protection of the physician. I'm thinking as a consumer. I sat here this entire time, having gone through here soon 4 epidurals with my wife in the last 5 years, and I'm just thinking as a consumer now, and not even a supporter of physicians in terms of protection right now. I'm a consumer this whole time, and I love it. We need this, and we're happy to communicate this to everybody on our platform, and we're grateful for you guys. I want to end with this, unless you guys have any other words. Bruce, do you have anything else?
No, I'm fine.
Are you sure? You were hurrying us up, and now, okay, all right.
Well,
So I appreciate that.
I'm good.
Justin,
I'm good.
hit on the petition one more time, would you please?
Yes, please go to change.org and search "Stop the Medicare Cuts for Physicians" and enter that, share it with your friends. We want to get as many people as possible behind this.
Please do share it, guys. Thank you. I take this being an industry guy just like you, Brad. I was thinking to myself, 1 in 4 physicians could be dealing with this stress at any given time, and here I am, a sales rep, trying to get them to try something new and those kind of things, and then even more than that, 99% of them are going to be facing this kind of
Right.
stress.
Right.
That was very informative to me. I promise that my apology and sympathy for you guys going through that is not just going to stop here with some words here, but I will give some words. I do believe that device companies should be locking arms with you on this, particularly the big device companies, and standing with physicians. So that is, it's live, it's recorded. Those are the words there. Device companies should stand up with the physicians on this and delivering this and protecting physicians. Thank you for your time. This has been a great episode 3 of 2024.
Gentlemen, you were
for
sharp.
joining
Thank
us.
you very much.
All right.
Appreciate your
Good
time.
evening.
Thank you.
Appreciate the time, guys.
Yeah.
Have a great
No
night.
problem.
All right.
Bye-bye.
Thanks. Bye.
Bye.